Did you know that subarachnoid hemorrhage, or SAH, is a condition that affects 9 every 100,000 individuals each year, with a higher prevalence in females? It's a significant topic in neurocritical care and the focus of today's discussion. Firstly, SAH is categorized into 3 types. The traumatic SAH is caused by direct injury, while the non-traumatic SAH is either non-aneurysmal paramesencephalic SAH, which is venous in origin or caused by other factors. These include aneurysmal SAH, AV malformations, connective tissue disorders, infective endocarditis, or reversible cerebral vasoconstriction syndrome. The most common sites of SAH are the ACOM, the PCOM, and the basilar artery. The symptoms of SAH are often preceded by a sentinel headache experienced by approximately 20% of patients. This is followed by a severe thunderclap headache and other signs of raised intracranial pressure, such as nausea, vomiting, diplopia, photophobia, cranial nerve palsies, and possibly loss of consciousness or focal neurological deficits. SAH is evaluated both clinically and radiologically, using various grading systems like the Hunt-Hess grading, the World Federation for Neurological Society grading, and the modified Fisher grading. The most frequently used diagnostic tool is the NCCT brain scan. This method boasts a sensitivity of 95 to 98% within the first 24 hours post-onset of symptoms, making it highly reliable in the early stages of SAH. However, it is not without its downsides, as this method's specificity can sometimes be lower, leading to potential misdiagnoses. On the other hand, the gold standard for diagnosis is the 4-vessel angiography, or DSA. This is a highly sensitive and precise method, but its utility is most pronounced within the initial 5 to 7 days of symptom onset. The downside with 4-vessel angiography, or DSA, is that it is more invasive than NCCT, carrying risks such as stroke or heart failure. Other useful diagnostic tools include an MRI angiography, which have lower sensitivity rates, but are safer alternatives as they are non-invasive. They are most effective within the first 72 hours following symptom onset. The CSF examination, on the other hand, is essential for detecting red blood cells or xanthochromia, indicative of a subarachnoid hemorrhage. However, it's an invasive procedure with potential risks, including headache, infection, and bleeding. Management of SAH is divided into 3 phases: acute, within the first 24 hours, subacute 24 to 72 hours, and delayed after 72 hours. The main complications in the acute phase are rebleeding, hydrocephalus due to a clot or blood in the intraventricular hemorrhage, and neurogenic stunned myocardium, also known as Takotsubo cardiomyopathy. There can be pulmonary edema due to stimulation of the beta receptors in the lung, and there can also be a seizure. However, the prophylactic use of seizure is not recommended, and if used, the anti-epileptic medications should be stopped as soon as the aneurysm is secured. The drug of choice for seizure prevention is levotraxetam. Phenytoin is now not recommended. Coming to the subacute phase, that is 24 to 72 hours, the common pathology underlying the subacute phase is a raise in the ICP, which further reduces the cerebral perfusion pressure and causes cerebral edema, which in turn again increases the ICP. Hence, the goal in the 24 to 72 hours window is to maintain a cerebral perfusion pressure of more than 70 millimeters Hg. The most notorious phase of the SAH is the delayed phase, which occurs from 72 hours to up until 3 weeks of the inciting event. There are 2 main complications in the delayed phase. The first is delayed cerebral ischemia, and the second being hydrocephalus. In the initial part of the understanding of SIH, delayed cerebral ischemia was considered to be due to delayed cerebral vasospasm. However, with time, we understood that vasospasm may be present in around 70% of the patients. However, symptoms of DCI may not be present in all of those, and hence, DCI is a better term than vasospasm. DCI is defined as a new onset focal neurological deficit, or a drop in GCS more than 2 for 1 hour, which is not attributable to any other factor, which is ruled out by a CT or MR preview, which includes a new onset infarct or a hydrocephalus. Multiple different etiologies have been proposed to explain the cause of DCI. However, still we do not know the exact cause. In the initial phase of our understanding of SAH, Triple H therapy was persistently used. However, with time we have realized that Triple H therapy is not effective and may be even harmful in the treatment of SAH. So prior to the onset of symptoms of DCI, try to maintain euvolemia. There is no need of hypertension or hemodilution. If the patient deteriorates and has a symptomatic vasospasm, we should go for induced hypertension with euvolemia, hypervolemia. However, if the patient is still refractory and deteriorates despite inducing hypertension, the patient should be immediately shifted to a cath lab, should undergo a DSA, and if needed, intra-arterial vasodilators in the form of nimodipine and milrinone should be used. The recent studies have suggested that the severity of vasospasm might be related to the severity of bleed, and hence there are ongoing trials regarding the need of ventriculosultomy to drain the blood or intrathecal tissue plasminogen activator to reduce the bleeding. Finally, we should also take care of the general ICU principles for pneumocritical care, which includes head elevation, adequate glycemic control, pain control, DVT prophylaxis. It should be started with mechanical prophylaxis, and once the aneurysm is secured, we can go for a pharmacological DVT prophylaxis in terms of low molecular weight heparin. Hyponatremia is one of the common findings in SIH. However, it seems to be more due to CSW as compared to SIADH. If, however, SIH is found to be the culprit of hyponatremia, the restrictive fluid strategy should not be used, and if necessary, 3% normal saline should be used to treat hyponatremia. To summarize, subarachnoid hemorrhage is a complex condition with various types, causes, and symptoms. It requires careful diagnosis using both clinical and radiological grading, and its management is divided into 3 key phases. This knowledge is crucial for medical professionals, particularly those specializing in neurocritical care. Stay tuned for more in-depth discussions on this and other related topics.